Welcome back to the deep dive. We often talk about complex topics here, trying to distill them down into something genuinely useful. And if you've ever tried looking up medical information, especially, say, around mental health treatments, it can feel like wading through, I don't know, a really dense forest sometimes, overwhelming. But what's really cool about modern medicine is how it's getting better and better at tailoring solutions, finding like the exact right tool for a specific job. So today, that's what we're doing. We're diving deep into a really crucial group of medications, second generation antipsychotics. You'll often hear them called SGAs. And these aren't, simple medications. They play a huge role in managing a whole spectrum of conditions, and understanding the nuances is just, well, it's key. Our mission today to really unpack these powerful tools, going beyond just what they are. We want to explore how they work, what makes each one unique, and importantly, the considerations that go along with using them. We've got this stack of flashcards, essentially, distilling the core info, guiding us through. And for you listening in, think of this as your shortcut to clarity. It's about getting a handle on the precise tools available, the specific benefits, and yeah, the really crucial trade-offs involved. It helps appreciate the sophisticated choices made in mental health care. We want you to have those aha moments where complex stuff just clicks. Ready? Let's dive in.
That's a great way to put it. Because what's so interesting about these SGAs is that while a lot of them share a kind of common biological starting point, the small differences in how they tweak brain chemistry lead to this remarkably diverse range of options. Each one really does have its own story.
Okay, perfect jumping off point then. Let's start with that common foundation. You mentioned most SGAs share this mechanism. They're D2 antagonists and 5-HT2A antagonists. Now, for those of us who aren't, deep into neurobiology, could you break that down? What does that actually mean, kind of high level, and why are those two targets so important?
Absolutely. So think of your brain using chemical messengers, right? Like dopamine, serotonin. They help nerve cells talk to each other. D2 antagonist basically means these drugs block a specific type, the D2 type, of dopamine receptor. Now, if dopamine activity is maybe too high in certain brain pathways, which we think happens in psychosis, blocking these receptors helps dial down symptoms, things like hallucinations or delusions.
Okay, so that's the dopamine part. What about the 5-HT2A, serotonin, right?
Exactly, serotonin. So 5-HT2A antagonism means they also block a specific serotonin receptor. And this isn't just like an add-on. This dual action, hitting both dopamine D2 and serotonin 5-HT2A, is thought to be why SGAs often work on a broader range of symptoms, maybe including some mood or cognitive aspects. And it's also probably why they tend to have a different, often maybe slightly better side effect profile compared to the older first-generation antipsychotics. This combination really sets the stage for how the individual drugs then start to differ, even though they share this initial approach.
Got it. So they're all kind of aiming for the same ballpark, but each one maybe throws a slightly different pitch. It's not just a blunt instrument. And speaking of unique and powerful, our sources really emphasize one drug in particular, clozapine. It keeps getting called the gold standard for treatment-resistant schizophrenia. That sounds huge. What makes it so uniquely effective?
It really is exceptional. And it earns that title because, well, it often works when nothing else has. We're talking about patients whose schizophrenia hasn't really responded well enough to at least two other antipsychotic trials. For them, clozapine can genuinely make a massive difference. But there's something else, a real clinical pearl, as the sources say, that's critical. It's proven effective for suicide prevention in schizophrenia.
Wow.
Yeah. That's not just another side benefit. It's a profound game changer, especially when you consider the tragically high risk of suicide in severe chronic schizophrenia. It means, even with all its challenges, clozapine offers something unique, a potential lifeline that can fundamentally alter someone's outlook.
That is incredibly powerful. So, okay, it's a D2 and 5-HT2A antagonist, like many others we'll discuss, but its impact is clearly just different. But with benefits that profound, there have to be significant downsides, right? The sources mention serious side effects, rigorous monitoring. What does that actually involve for someone taking it? What are the big risks?
You hit it exactly. That unparalleled effectiveness comes at a price, demanding really strict monitoring and commitment from everyone involved, patient, doctors, pharmacy. The biggest concern, the most well-known, is a granulocytosis. That's a dangerous drop in white blood cells, specifically neutrophils, which you need to fight infection. It can be life-threatening.
Okay, so how do you watch for that?
Constant vigilance. Patients need regular blood tests, often weekly when they first start for about 6 months, then maybe every 2 weeks, and then monthly long-term just to check their absolute neutrophil count, the ANC. If those numbers drop too low, you have to stop the clozapine immediately.
Wow, okay. That's intense. Are there other serious ones?
Yes, definitely. There's myocarditis, inflammation of the heart muscle. Seizures are another risk, so you have to start the dose low and go slow and be careful with other meds. And then there's metabolic syndrome, significant weight gain, potential for high blood sugar, cholesterol issues, plus pretty heavy sedation for many people, and sometimes coeluria, which is just excessive drooling or salivation.
So it's a constant balancing act.
Absolutely. Weighing these serious risks and the hassle of monitoring against clozapine's unique, often life-saving benefits, particularly in those really tough treatment-resistant cases, it says a lot about its power that we do go to these lengths.
It really does. Okay, so moving from that unique standout, let's talk about a group of SGAs often linked by a common and often pretty challenging issue, their metabolic impact. We're talking weight gain, other metabolic changes being a primary concern here.
Yeah, this group is really important to understand because these side effects aren't trivial. They can lead to long-term health problems like diabetes, heart disease, and critically, they can really affect whether someone sticks with the treatment. I mean, nobody wants to gain a lot of weight or feel tired all the time. It impacts quality of life.
Makes sense. Let's start with olanzapine. The notes say very effective but limited by metabolic risk. Tell us more about that balance.
Olanzapine is, well, it's a powerhouse for managing psychosis and mood symptoms. Very effective for many. But it's kind of notorious for causing significant weight gain, often among the worst offenders in the SGA class. And it carries a high risk of metabolic syndrome overall.
Meaning the whole cluster. High blood sugar, cholesterol.
Exactly. High blood sugar, increased cholesterol, sometimes blood pressure issues too. It really bumps up cardiovascular risk long term. Plus, patients often experience pretty significant sedation and also anticholinergic effects, things like dry mouth, constipation, blurry vision. Annoying stuff that adds up. Its mechanism is that D2 plus 5-HT2A antagonism we talked about, but something about its specific binding just seems to drive these metabolic and sedation issues more strongly.
Okay, a lot to weigh there. Then there's risperidone. What are its key features? Side effects? Uses?
Risperidone is another workhorse, also a D2 and 5-HT2A antagonist. A key side effect to know about is hyperprolactinemia, elevated prolactin levels.
And what does that mean for a patient practically?
For patients, that can mean things like irregular periods for women, sometimes breast tenderness or even milk production in men and women, sexual side effects. It can be quite bothersome. It can also cause EPS, those extrapyramidal symptoms, movement issues like stiffness, tremors, or that awful inner restlessness called akathisia, especially if you push the dose higher. Weight gain is also definitely a possibility, though maybe not quite as universally severe as with olanzapine.
And its uses?
Besides schizophrenia, it's used a lot for bipolar mania and also for managing irritability associated with autism spectrum disorder. So, pretty versatile.
Okay. And then closely related, we have paliperidone. What's the story there? How is it different, especially in how it's given?
Right, so paliperidone is actually the main active metabolite of risperidone. Basically, it's what risperidone turns into in your body that does the work. It works well on its own. But the real standout feature and a huge advantage for making sure people actually get their medication consistently is the long-acting injectable form.
The depot injection.
Exactly. Instead of daily pills, a patient can get an injection, say, once a month, or even less often with some newer versions. That bypasses the whole issue of remembering pills every day, which can be tough in chronic illness.
That seems like a big deal for adherence. Side effects similar to risperidone.
Pretty much, yes. You still see the risk of prolactin elevation and EPS, but that convenience factor of the injectable, for many people, that's a game changer.
Definitely. Okay, so we've hit some big players, dealt with the metabolic stuff, even injectables. What about SGAs that offer maybe a different trade-off profile? Let's look at some with more unique characteristics.
Yeah, this is where you really see the fine-tuning happening. More tools for specific situations or patient sensitivities.
Let's start with quetiapine. Our notes say D2 plus 5-HT2A antagonist, standard enough, but then low binding. What does low binding to that D2 receptor mean in practice?
That low binding is actually a key feature. Practically speaking, it often means a lower risk of those movement side effects, the EPS we just talked about with risperidone. That can be a major plus for comfort and sticking with the med.
Okay, so less risk of stiffness or tremors maybe, but what are its downsides?
Well, it definitely has its own issues. Significant sedation is a big one. It often makes people quite sleepy, so it's usually taken at night. Also, orthostatic hypotension, that's getting dizzy or lightheaded when you stand up quickly because your blood pressure drops. And it does still carry some metabolic risk, though maybe not typically as severe as olanzapine.
Interesting. And it seems to have diverse uses.
Very diverse. Beyond schizophrenia, it's widely used for bipolar depression, sometimes just for insomnia at lower doses, and even for psychosis and Parkinson's disease. That low D2 binding makes it useful in situations where you really want to avoid movement side effects.
Quite the range. Okay, next, ziprasidone. There's a practical note here. Must take with food for absorption. That seems critical.
Absolutely critical. Yeah, if ziprasidone isn't taken with a decent-sized meal, like at least 500 calories, you just don't absorb it properly. The patient won't get the effective dose. So that's vital education.
Good to know. What about its side effect profile?
The main thing to watch for is QT prolongation. That's a change on the EKG, the heart tracing, that in rare cases could increase risk for serious heart rhythm problems. So sometimes baseline or follow-up EKGs are needed. But the big advantage, notably less weight gain compared to many others. That makes it a really valuable option if metabolic concerns are high on the list. Mechanism is still D2 plus 5-HT2A antagonism.
Less weight gain is definitely a plus. Okay, and another one with a food requirement, lurasidone. What's its story?
Yep. Lurasidone also needs to be taken with food, maybe around 350 calories for this one again for good absorption. Mechanism-wise, it's D2 plus 5-HT2A antagonist, but our sources highlight it also acts on 5-HT7 receptors.
5-HT7, what's the thinking there?
Well, hitting that extra serotonin receptor, 5-HT7, is thought to potentially contribute to its effects on mood and maybe even cognitive function. It might be part of why it works well for bipolar depression. Common side effects can include akathisia, that restlessness again, and sometimes nausea. But importantly, it's known for minimal weight gain. Huge plus.
And specifically approved for bipolar depression.
Correct. That's a key indication for it, offering a targeted treatment option within the SGA class for that specific condition.
This is fascinating, the level of detail and difference. It really drives home that these aren't just, interchangeable pills. Which brings us to another really interesting group, the partial agonists, sometimes called dopamine stabilizers. Now, that sounds fundamentally different from the antagonists we've been discussing.
It is, yeah. It's a different way of thinking about influencing the dopamine system. Instead of just blocking the D2 receptors completely, these drugs are partial agonists, meaning they stimulate the receptor, but only partially less than dopamine itself would. The clever part is, where dopamine levels might be too high, like in psychosis, they act kind of like a blocker because they displace the full agonist, dopamine. But where dopamine might be too low, maybe contributing to negative symptoms or depression, they provide a little bit of stimulation. So the idea is to stabilize dopamine activity, bringing it towards a more normal level, rather than just shutting it down, like a dimmer switch, not just on-off.
Okay, a dimmer switch for dopamine, I like that. Aripiprazole is the classic example, right? Partial D2 agonist, dopamine stabilizer, plus the 5-HT2A antagonist action. What's its profile like?
So imipiprazole, with that unique mechanism, aims for that nuanced dopamine regulation. Common side effects. Akathisia can definitely be an issue for some people, and insomnia too. But the big advantage, again, is generally less metabolic risk compared to drugs like olanzapine or risperidone. That's a major selling point. And it's also widely used as an adjunct in depression, added on to an antidepressant when that alone isn't quite cutting it. Shows its broader role.
Right. Then we have brexpiprazole. The notes say similar to aripiprazole. How close are they? Any key differences?
Yeah, brexpiprazole is very much in the same family, same core mechanism, partial D2 agonist. It also carries a risk of akathisia. It might cause some mild weight gain, but still generally less than the high metabolic risk agents. And like aripiprazole, it also has that specific indication as an adjunct for major depressive disorder.
So why choose one over the other?
It often comes down to subtle differences. Maybe slightly different binding affinities at various receptors could mean one is tolerated better than the other by a specific person, or maybe slightly more effective for their particular symptom mix. It's often about individual trial and response.
Okay. And the last one in this group, cariprazine. Also a partial agonist, but with a twist. Partial agonist at D2-D3, prefers D3. What's the significance of preferring D3?
That D3 preference is interesting. D3 receptors are found in high concentrations in brain areas linked to things like mood, motivation, and reward pathways. So the thinking is that by having more action at D3, cariprazine might be particularly helpful for certain symptoms.
Like what?
Side effects include akathisia and insomnia, similar to the others, and again, less metabolic risk. But its potential niche seems to be being good for bipolar depression and negative symptoms. Negative symptoms of schizophrenia, things like lack of motivation, flat affect, social withdrawal, are notoriously hard to treat. So if cariprazine has an edge there, potentially due to that D3 action, That's a really significant potential benefit.
Wow. Okay, this has been incredibly detailed. It's really striking, isn't it? Just how many different ways these medications tackle broadly the same goal, and how those sometimes subtle differences in mechanism or binding create such distinct profiles in terms of what they treat best and what side effects you need to watch for. It's definitely not a one-size-fits-all class of drugs.
Absolutely. And if you sort of zoom out, connect this to the bigger picture, you see these aren't just interchangeable pills you can grab off the shelf. Each one really does have its own specific place, its own unique balance between how well it works for certain symptoms and the specific side effects it brings. Clinicians have to weigh all that incredibly carefully for every single patient, which raises that crucial question. How do you tailor treatment effectively when the options of this varied, when individual patient responses are so different, and when the side effects can be so impactful? It's a constant, dynamic process.
Exactly. And understanding this detail, hopefully for you listening, helps make sense of why mental health treatment plans are so incredibly individualized. It explains why maybe a medication works wonders for one person but is just intolerable for another. That one-size-fits-all approach, it just doesn't fly here. It really speaks to the sophistication needed to manage these conditions well. So let's recap. We've taken quite the journey through second-generation antipsychotics today. We saw the huge diversity here. From clozapine, that powerful gold standard needing intense monitoring but offering unique benefits, especially for treatment resistance and suicide prevention, to that group where managing metabolic effects like weight gain is a major focus, olanzapine, risperidone.
Hmm.
Then those with unique features like quetiapine's low D2 binding or the food requirements for ziprasidone and lurasidone, often with less weight gain. And finally, the partial agonists, aripiprazole, brexpiprazole, cariprazine offering that dopamine stabilizing approach, potentially lower metabolic risk, and specific uses like augmenting depression treatment or targeting negative symptoms. Each one, as we saw, has its own fingerprint. A real balance of benefits and specific side effects.
Yeah, this whole exploration really underscores that treating mental health conditions is this highly personalized craft, doesn't it? It's about constantly blending the scientific knowledge with the individual patient's unique needs, their responses, their preferences.
Couldn't agree more. And it leaves us with something to chew on, a final thought for you. When you consider this really intricate dance between a drug's precise action in the brain, its sometimes profound benefits for specific conditions, and its own unique list of potential side effects, what does that complexity tell us about the future of personalized medicine in psychiatry? And maybe what's the ongoing challenge in truly optimizing well-being for every single individual facing these conditions? What stood out to you most today? Was there a detail about one of these medications that surprised you or made you think differently? Something to reflect on. Thanks so much for joining us on this deep dive. We really hope this gave you a clearer, maybe more nuanced view of the sophisticated choices involved in mental health care today. Until next time, keep digging deeper.